Hello. Today we have an interesting rare case of GN with extrarenal manifestations. He is a 65-year-old man who came in with nausea, loss of appetite, difficulty breathing, some leg swellings, and he reported having less urine output. Blood pressure was mildly elevated, heart rate 92, respiratory rate 16, oxygen saturation 92% on room air. He had bilateral basal crackles with peripheral edema, and his skin looks pale. His lab showed a serum creatinine of 4.5 milligram per deciliter and hemoglobin of 9.7 grams. Renal biopsy is performed, and the patient was started on immunosuppressants, and he responded to therapy. Here is his light microscopy picture, and as you see, he has some crescent, and here is the immunofluorescence, which was very positive for linear staining with IgG. And here is the question: which of the following is a risk factor for relapse of this disease? Is persistent pulmonary symptoms after treatment is associated with more relapse, or 30% crescent in renal biopsy, or presence of anemia, or presence of pulmonary radiologic findings, or persistence of antibodies after treatment? Which one of those is associated with higher risk of relapse? And the right answer is persistence of antibodies after treatment is associated with higher risk of relapse. And patient with good posture, as this patient who has pulmonary renal syndrome with crescentic RBGN and also linear IgG staining in the immune fluorescence. That's very typical for the good posture syndrome or anti-GBM disease. So the antibodies here are against the autoantigen in the GBM and also in the alveoli. Pulmonary symptoms along with AKI is very typical, and these patients in the kidney biopsy usually have proliferative or necrotizing GN with cellular or fibrocellular crescents. If treatment is delayed or if the patient presented late, this cellular crescent changed aggressively to fibrous crescent with glomerulosclerosis and interstitial fibrosis, and the prognosis would be dismal. Therapy should be started right away. However, if the patient have aggressive disease that require renal replacement therapy, these patients don't usually respond to therapy and will have end-stage kidney disease. All patients with pulmonary symptoms, regardless of their renal manifestation, should be treated with immunosuppressive therapy. Patients should be started on plasma exchange and destroyed as a combination therapy from the beginning. The circulating antibody disappear usually within 8 weeks of therapy, but an early relapse, which usually happen within 2 months, may happen if the circulating antibodies persist. So persistence of the anti-GBM antibody is associated with higher relapse. And here are the references. And don't forget, if the patient presents with aggressive renal disease that require renal replacement therapy, usually he or she doesn't respond to therapy. However, we may need to give therapy just for the extrarenal manifestation, not for the renal manifestations. And here are the references. And thank you so much.